A tumor the size of a lime is compressing this patient's optic chiasm. His prolactin comes back at 164 nanograms per milliliter, barely 3 times normal. The lab was wrong by a factor of nearly 200. After serial dilution, that same sample measured 26,000 nanograms per milliliter. This is the high-dose hook effect, and it can happen with almost any two-site immunoassay you run today. This isn't a rare curiosity for the boards. High-dose hook effect has been documented in beta-HCG, prolactin, thyroglobulin, ferritin, PSA, TSH, and CA-125 assays across essentially every immunoassay platform in clinical use. Miss it, and a patient with a massive tumor burden can look biochemically reassuring on paper. Myth: a low number on the report means a low concentration in the tube. Fact: in a two-site sandwich assay, the dose-response curve isn't a straight line all the way up. It rises, peaks, and bends back down at extreme antigen excess, producing a falsely low or even undetectable result. At serum HCG concentrations above roughly 500,000 milli-international units per milliliter, several widely used immunometric assays begin to underread, sometimes reporting values low enough to look non-pregnant. The formal definition: the hook effect is a dose-dependent, assay format-dependent artifact in which analyte concentrations exceeding the reagent antibodies' binding capacity generate a falsely low signal instead of an accurately high one. For clinical settings, should raise your suspicion immediately. A giant pituitary mass with only mild hyperprolactinemia, a strongly suspected molar pregnancy with a negative urine HCG, an undetectable thyroglobulin in a patient with obvious metastatic disease on imaging, and extreme ferritin elevation suspected in hemophagocytic syndromes. On one side, a patient with a 10-centimeter skull base mass. On the other, a lab value suggesting only mild hyperprolactinemia. That mismatch is the entire clue, and it's one every clinician can learn to catch. Over the next several minutes, we'll break down exactly why this happens at the molecular level, which analytes and assay formats carry the highest risk, and precisely how laboratories catch and correct it before it reaches a chart. Every two-site sandwich immunoassay follows the same basic architecture. A capture antibody is immobilized on a solid phase, a bead, a well, or a magnetic particle. The patient's sample is added, and if the target antigen is present, it binds the capture antibody. A second, labeled detection antibody then binds a separate epitope on that same antigen molecule, forming a three-part sandwich whose signal is proportional to antigen concentration. This design is called an immunometric, or non-competitive, assay. Distinct from older competitive immunoassays where labeled and unlabeled antigen compete for a limited number of antibody sites. Immunometric assays dominate modern automated platforms precisely because they're fast, sensitive, and have a wide dynamic range under normal conditions. The capture and detection antibodies must recognize two spatially distinct, non-overlapping epitopes on the antigen. If both antibodies could bind the same site, they'd compete rather than cooperate. So manufacturers select monoclonal antibody pairs specifically for their complementary epitope targets. Clinical Pearl. Picture the antigen as a scaffold with two distinct docking sites. Under normal conditions, one antigen molecule bridges a capture antibody on one side and a detection antibody on the other, and that bridge is precisely what generates your signal. Not all sandwich assays are built the same way. One-step assays mix sample, capture antibody, and labeled antibody together simultaneously, faster but riskier. Two-step assays incubate the sample with capture antibody first, wash away everything unbound, and only then add the labeled detection antibody. That single wash step fundamentally changes hook effect risk, which we'll return to shortly. In a two-step workflow, that wash step removes any antigen that never engaged the capture antibody, including free antigen at supraphysiologic concentrations. It's a built-in safeguard, though as we'll see shortly, not a complete one. Every validated immunoassay has a defined analytical measuring range, the concentration window across which the signal-to-antigen relationship is linear and trustworthy. Push far enough past the top of that window, and you're in territory the calibration curve was never designed to interpret correctly. Clinical Pearl. The two antibodies must each have adequate affinity and be present in sufficient molar excess relative to the expected physiological antigen range. Manufacturers calibrate this balance carefully, but that calibration assumes the antigen concentration stays inside the range they anticipated. Reagent antibody concentration is fixed by the manufacturer at manufacture time. It doesn't scale up just because your patient's antigen level does. That fixed ceiling is the entire vulnerability we're about to unpack. So what actually happens, molecule by molecule, when antigen concentration overwhelms that fixed antibody supply? That's where the real mechanism begins. Plot signal against log antigen concentration, and you get a curve that rises steeply through the clinically normal range, flattens near the assay's designed ceiling, and then, instead of plateauing, bends downward. That downward bend is where the hook effect gets its name, and it can drop the signal back down to values seen at low or even normal antigen concentrations. Here's the causal chain. Antigen excess means there are far more antigen molecules than there are capture and detection antibody binding sites combined. Individual antigen molecules independently saturate capture sites and detection sites separately before any single molecule gets the chance to bridge both. No bridge, no sandwich, no signal, regardless of how much antigen is actually in the tube. This isn't unique to modern immunoassays. It's classical immunochemistry. The Heidelberger-Kendall-Precipitin curve described the same three zones back in the 1930s: antibody excess, equivalence, and antigen excess. What we now call the hook effect is the immunometric assay expression of that same antigen excess zone. Bound signal doesn't track antigen concentration linearly once you cross into that zone. It tracks the probability that a given antigen molecule happens to be captured on one antibody at the same moment a labeled antibody finds it. At extreme antigen to antibody ratios, that joint probability falls fast. Keep this in mind as we walk through real cases in a moment. The exact same physics applies whether we're talking about prolactin, HCG, or thyroglobulin. Think of it as a grid. Rows for capture antibody occupancy, columns for detection antibody occupancy. Peak signal occurs only in the narrow band, where both antibodies are simultaneously occupied by the same antigen molecule. Extreme antigen excess pushes both antibodies toward full independent saturation, off that productive band entirely. A given patient sample sits somewhere on that continuum. Most results land comfortably in the linear zone. It's only the outliers, extreme tumor burdens, massive trophoblastic disease, hyperinflammatory Ferritin storms, that cross into hook territory. Compare two samples with wildly different true antigen concentrations. One sits mid-curve and reads correctly high. The other sits far past the peak and paradoxically reads similar to, or even lower than, a genuinely normal sample. This is the paradox that trips up even experienced clinicians. Diluting a hooked sample doesn't dilute the true signal away. It pulls the sample back down into the antibody's working range, so the reported concentration goes up, not down, after dilution. You can think of the assay's own linear range as a therapeutic window in reverse. Stay inside it, and results are trustworthy. Cross the upper boundary, the assay's own excess dose of antigen, and accuracy inverts rather than simply flattening out. Lock in the mechanism with one phrase: both hands. Picture the antigen as a coin that needs one hand from the capture antibody and one hand from the detection antibody to be held up together. Flood the room with coins, and every hand grabs its own coin. Nobody's holding one up together anymore. Not all hooks are the same phenomenon. High-dose hook, true antigen excess in a two-site immunometric assay, is what we've been describing. Prozone, in the strict historical sense, describes antibody excess in agglutination or precipitation reactions, a related but mechanistically distinct phenomenon that predates modern sandwich immunoassays. In practice, the two terms are often used interchangeably, but the distinction matters when you're troubleshooting. Several assay design variables determine how far up the concentration curve the hook point sits. Lower antibody affinity, shorter incubation times, and, most importantly, one-step simultaneous addition formats all push the hook threshold lower, making the artifact more likely within concentrations you'll actually encounter clinically. Two-step assays don't eliminate hook risk entirely. They simply shift the threshold to a much higher, less clinically common concentration, because the wash step removes most, though not all, of the antigen that never engaged the capture antibody. Published thresholds vary by platform and reagent lot, but rough clinical benchmarks are useful. Hook effect in HCG assays has been reported above roughly 500,000 milli-international units per milliliter. For prolactin, giant macroprolactinomas producing tens of thousands of nanograms per milliliter are the classic trigger. Thyroglobulin and ferritin hooks tend to appear at similarly extreme, disease-defining concentrations. If you rank assay formats by relative hook vulnerability, lateral flow point of care tests, and one-step chemiluminescent immunoassays sit at the higher risk end, while two-step sequential immunoassays with generous antibody excess sit at the lower risk end, though still not risk-free. When a result doesn't fit the clinical picture, hook effect is only one item on the differential. Also consider heterophile or human anti-animal antibodies and biotin interference on streptavidin biotin platforms. The distinguishing clue for hook effect specifically is that dilution paradoxically increases the reported value. Hook effect has been documented across chemiluminescent immunoassay, enzyme immunoassay, immunoradiometric assay, and lateral flow point of care platforms alike. No single technology is immune. It's a structural feature of the two-site sandwich design itself, not a flaw unique to one manufacturer. Trace the fate of antigen molecules in a hooked sample. Nearly all of them bind somewhere, but only a small fraction end up correctly bridged between capture and detection antibody. And it's that shrinking fraction, not the total antigen load, that the instrument actually reports. Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming. Format matters, affinity matters, and dilution behavior is your single best bedside clue for telling hook effect apart from every other interference on this list. Take the landmark case published in Endocrine Practice. A 65-year-old man presented with headaches, personality changes, and pertussis. MRI showed a 10-centimeter, locally invasive mass at the skull base. Initial prolactin, 164.5 nanograms per milliliter, only mildly elevated, and easily mistaken for stock effect hyperprolactinemia from a non-functioning tumor. The imaging alone should have raised suspicion. A mass of this size producing only mild prolactin elevation is biologically implausible for a lactotroph tumor. That mismatch between tumor bulk and hormone level is the single loudest clinical clue to hook effect. Serial dilution of the original sample revealed the true story. 26,000 nanograms per milliliter, roughly 158 times the undiluted result. A postoperative diluted sample still measured 22,000. Dopamine agonist therapy, not surgery for a non-functioning tumor, was the correct next step. Now a second scenario. An 18-year-old woman presents with 16 weeks of amenorrhea, lower abdominal pain, and a uterus large for dates. Ultrasound shows a classic snowstorm pattern of complete molar pregnancy. Her qualitative urine HCG test reads negative. Delayed recognition carries real stakes. In reported cases of hook effect-related diagnostic delay, patients have presented emergently with hemorrhage or an acute abdomen before the true HCG level, and the underlying diagnosis was ever confirmed. Clinical Pearl. This is exactly why emergency departments and early pregnancy units are taught not to fully trust a single negative qualitative HCG when the clinical and sonographic picture strongly suggests otherwise. The point-of-care test itself is a one-step, hook-vulnerable format. A third pattern shows up in oncology follow-up. Differentiated thyroid cancer patients are monitored with serial serum thyroglobulin after thyroidectomy and radioiodine ablation. A rising level should flag recurrence. In documented cases, patients with extensive metastatic disease on imaging have had thyroglobulin come back undetectable or surprisingly low, a result that, taken at face value, would falsely reassure both patient and oncologist that the cancer was quiescent. Beyond these three, keep a mental shortlist of high-risk analyte-disease pairs. PSA in bulky metastatic prostate cancer, CA. 125 in advanced ovarian carcinoma with large volume ascites, ferritin in severe hemophagocytic lymphohistiocytosis, and free light chains in high tumor burden multiple myeloma. Correct identification changes management directly. Once hook effect is confirmed, first-line therapy for macroprolactinoma is a dopamine agonist like cabergoline, not surgery. Dopamine agonism suppresses lactotroph prolactin secretion and often shrinks the tumor itself, sparing the patient in unnecessary craniotomy. Quick check. A patient with a massive pituitary mass has a prolactin that seems only mildly elevated. What's your very next step before accepting that number? Most labs now run a simple decision pathway whenever a result looks clinically implausible. First, does the result conflict with the clinical picture, imaging, or trend? If yes, dilute the sample, commonly 1 to 10, 1 to 100, sometimes further, and repeat the assay. If the diluted result comes back proportionally higher rather than lower, hook effect is confirmed, and the corrected diluted value becomes your reportable result. Interpreting a dilution series takes a bit of discipline. Expect the corrected concentration, the diluted result multiplied by the dilution factor, to land in the same neighborhood across at least 2 dilution steps. If it does, you've found linearity, and you can trust that corrected value. Because clinicians can't always flag every high-risk sample in advance, many laboratories build reflex dilution directly into the analyzer's protocol for known high-risk analytes, automatically retesting any HCG, prolactin, or ferritin result above a preset threshold at a standard dilution, without waiting for a clinician to ask. Clinical Pearl. When labs validate a reflex dilution protocol, they compare the corrected diluted result against an independent reference method, often a 2-step assay or an orthogonal platform, using a bland Altman plot to confirm the 2 methods agree within acceptable limits across the extended range. Plot the corrected concentration from each dilution step against the dilution factor itself. A properly hooked corrected sample shows a flat, parallel line. A sample still climbing steeply with each additional dilution likely needs 1 more dilution step before you trust the number. Newer chemiluminescent analyzers add a kinetic safeguard, reading the signal at 2 separate time points during incubation rather than once at the end. A true high-concentration sample keeps climbing between reads. A hooked sample shows an early peak followed by a decline, a pattern the software can flag automatically. Manual dilution and automated on-board hook detection each have trade-offs. Manual dilution is simple and universally available, but relies on someone recognizing the discordance in the first place. Automated kinetic algorithms catch cases nobody flagged clinically, but they add cost, aren't available on every analyzer, and still need periodic verification. At the bench, the practical technique is straightforward. Prepare dilutions in assay matrix diluent, never plain saline, which can distort protein binding behavior. Mix thoroughly, reassay promptly, and always run the original undiluted result alongside the dilutions so you can see the full curve shape in one batch. Formal accuracy data on automated hook detection algorithms are still limited, but published validation work suggests high sensitivity for flagging classic high-dose hook patterns, with occasional false positives in samples with unusual non-hook interference, which is exactly why a flagged result still warrants manual dilution confirmation rather than automatic acceptance. We're now over halfway through. Next, we'll look at how manufacturers engineer assays to push that hook threshold as far out of clinical reach as possible. Manufacturers mitigate hook risk at the design stage in several ways. Engineering higher affinity antibody pairs, deliberately loading reagent antibody in generous molar excess relative to expected pathological concentrations, favoring 2-step wash formats for high-risk analytes, and validating an extended measuring range with documented hook thresholds in the package insert. Clinical Pearl. Some manufacturers add a 3rd reagent step entirely, an additional aliquot of capture antibody introduced after the initial incubation, specifically to mop up any antigen that escaped the first round of binding and push the hook threshold to a concentration essentially never seen clinically. How well do these engineering fixes actually hold up? A 2022 study specifically re-examined whether the high-dose hook effect still occurs in modern prolactin immunoassays despite decades of design improvements, and confirmed it can still happen, even on contemporary automated platforms, reinforcing that engineering has reduced, but not eliminated, the risk. Before an assay ever reaches your analyzer, its hook threshold is characterized during pre-market validation, spiking samples with supraphysiologic antigen concentrations, mapping the full dose response curve, and documenting the concentration at which signal begins to decline, all disclosed in the package insert's analytical performance section. On the ordering clinician side, a short checklist prevents most missed cases. Flag any result that doesn't match the clinical severity, Request dilution explicitly for known high-risk conditions, and never let a single automated result override strong clinical or radiologic evidence. One more engineering angle before we wrap up with the pearls you'll actually use at the bedside or the bench. Weighing the trade-offs. No single mitigation strategy is perfect on its own. Higher antibody affinity improves specificity but adds reagent cost. Two-step formats reduce hook risk but slow turnaround. The strongest real-world protection is layering several of these strategies together rather than relying on any one fix alone. Before we close, a rapid recap. Why does antigen excess drop the signal instead of raising it? Because individual antigen molecules independently saturate capture and detection antibodies before a bridge can form. What's the single best bedside clue? A reported value that paradoxically rises after dilution. And the most effective operational fix? Reflex dilution protocols for known high-risk analytes and conditions. One final caution, don't overcorrect. Reflexively diluting every result wastes reagent and time, and dilution itself introduces its own small imprecision. Reserve dilution testing for results that are genuinely discordant with the clinical picture or for predefined high-risk analyte condition pairs. Final myth versus fact. Myth: modern automated analyzers have engineered this problem away. Fact: hook effect remains a documented, reproducible artifact on current generation platforms. Vigilance is still required. Carry one equation-shaped rule in your head. Signal is proportional to bridged complex, not to total antigen. Past the hook point, those two stop tracking each other. Remember your 4 highest yield clinical pairs: giant pituitary mass with mild prolactin, suspected molar pregnancy with negative HCG, metastatic thyroid cancer with undetectable thyroglobulin, and suspected HLH with a ferritin that seems too low for the clinical severity. Your 2-item action plan. When the lab result and the clinical picture disagree, dilute before you diagnose. And communicate your suspicion directly to the laboratory so it can be acted on quickly. And keep both hands in your back pocket. The antigen needs one hand from each antibody to be seen. Flood the system, and every hand ends up holding its own, separate coin. The number on the screen is only as trustworthy as the assay that produced it. Know when to question it. Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.